navigating Medicare's landscape. So, Nicole, I will hand it over to you if you're ready.
Thank you very much. Thank you everybody for having me. Happy October 29th. Is everybody like prepared that we're going to be flipping the calendar over the weekend to November? I know I've got my sweater on, but it just hasn't hit me that we've already come to the end of October. As Stephanie mentioned, we're going to talk about telehealth today. We're going to talk about navigating Medicare's landscape. So knowing that there's been a lot of buzz and a lot of activity, this is a hot topic right now. So hopefully we can, answer some questions or reaffirm some of the information and things that you may have been reading or clarify some things. Please, we like this to be interactive. Take yourself off of mute if you want, raise your hand, put your information in the chat. We will do our best to try to get to everybody's questions as much as we possibly can. And if we don't get to some, we'll do our best to collect all of that information that is in the chat that we didn't get to answer those questions, and then we will work to get responses out in a timely manner. So we're going to kind of approach today's discussion around telehealth from a timeline perspective. We're going to just briefly talk about what telehealth is. We're going to talk about a timeline, and then we're going to address some billing and payment components. So just getting right into it. So we have a lot of information to cover. Telehealth in and of itself is defined as the use of electronic information and telecommunication technologies to provide care when the patient and the provider are not in the same location. So for those of you who know me, I kind of live by the KISS principle, keep it simple, silly. So I kind of try to keep things as simple and straightforward as possible. Our originating site is where a patient is getting services. So basically where the patient is located. The distant site is where the physician or the practitioner is providing that service. So where the physician is located is our distant site, and originating site is where the patient is located. And the modalities for performing telehealth have historically been audio, video, or audio only. So let's kind of jump right into the timeline of the pandemic, pre-pandemic. So we had telehealth in a pre-pandemic, pre-COVID-19 public health emergency pandemic. We had the telehealth during the COVID-19 public health emergency, and then we had telehealth post-COVID-19. And we're still in, right, that post-COVID, but we've got different stages of post-COVID public health emergency telehealth. So if we come back to the pre-COVID, patients needed to get telehealth at an originating site, and it needed to be services located in a certain geographic area. Only certain types of distance site providers could provide and get paid for telehealth. And FQHC was not one of them that could be a distance site provider pre-pandemic, which we're going to talk about. Prior to the pandemic, an FQHC was able to be an originating site provider and bill for that service, which we'll talk about what those codes are in just a moment. So originating site, remember, is where the patient is located. So an example, just to kind of get everybody on the same page, is if you as an FQHC primary care provider had a visit with one of your patients, and that primary care provider said, Nicole, we need to have you have an appointment with a cardiologist or a podiatrist. And that cardiologist or podiatrist is 6 hours away. Instead of you driving that 6 hours, Nicole, you can come into our clinic and we can do a telehealth visit with that external cardiologist or podiatrist that's 6 hours away. That meant you as the FQHC, because the patient was physically located in your health center, you were considered the originating site provider. The provider for the cardiology, the podiatry component, that physician would have been the distant site provider. Okay, so that's what we were able to do all the way up until we had the COVID-19 public health emergency, and then we became eligible for additional benefits or flexibilities when the pandemic occurred. Okay, so we're now in the not to bring everybody back there, but we're from a telehealth perspective, we're now back during the time frame of the public health emergency. And we have emergency waivers and other regulatory authorities to provide services to patients via telehealth. Patients were able to get telehealth wherever they were located. They may have been in their home, they may have been in their car, they may have been at a family member's house, they could have been on vacation, whatever the case may be. It didn't matter where the patient was, they were able to get care wherever they were located. There were no geographic restrictions. And then all providers who were eligible to bill Medicare for professional services were permitted to be the distant site providers. So that included an FQHC or an RHC can be a distant site provider. So again, I may have just FQHC mentioned in here. Know that we're talking about FQHC and RHCs in this space, okay? So we had this process of what we were doing for many, I'm saying many because we had this over many years as we were going through and working our way out of the public health emergency. When the public health emergency ended, the flexibilities continued, and we're going to talk a little bit about the timeline as we go through our next couple slides. So we had flexibilities after the public health emergency ended that were either continuing to be extended. In some cases, some things were made permanent. And I kind of put here, it was extended until it wasn't, because we are currently in this expiration period, but we don't know if anything could change. And then we can have this kind of expiration period squashed and what those rules might look like. So right now we're in this, it was extended until it wasn't kind of period. Okay, so let's start with behavioral health. So effective January 1 of 22, mental health services, mental health visits using interactive real-time telecommunications technology were able to be, were made permanent in this telehealth space. We can perform them audio video. We can perform them audio only where patients can't access or don't consent to audio video technology. And we report and get paid the same way as we do as an in-person visit. So when you see a behavioral health patient for therapy purposes, for psychotherapy, those are those services that Medicare has made permanent as of January 1 of 22. When we submit our claims to Medicare, ultimately, we have to communicate that we performed the service either without modifiers, and it tells the payer that we did this as an in-person visit, or we add modifier 95 to say it was an audio video visit, or we add modifier FQ or 93 to say that it was an audio only visit, and we append these modifiers to the G codes. So when I say the G codes, we're talking about our G0469 or G0470, okay? The other element that kind of kept getting kicked down the road in the behavioral health space was the requirement of an in-person mental health visit 6 months before the telecommunications visit happened. There must be an in-person mental health visit at least every 12 months. All of that kept getting kicked down the road, okay? During the recent timeline that we're talking about, Section 4113 of the Consolidated Appropriations Act delayed that in-person requirement under Medicare for mental health visits for RHCs and FQHCs provided via telecommunication technology. In other words, for RHCs and FQHCs, they are not requiring an in-person visit until January 1 of 2025, which is what came out in this ruling, okay? We then had the Medicare Physician Fee Schedule final rule for 2025. For FQHC and RHC non-behavioral health, we were going to be able to continue to bill for services furnished using telecommunication technology with the use of G2025. We were doing this via audio only or audio video visits. And we had this permitted through December 31 of 2025. That was what was in the final rule that came out within the first week or two, I don't remember the exact date, of November of 2024. The payment was going to be based on the average amount for all physician fee schedule services that were on the CMS telehealth list, weighted by volume. And they were delaying the in-person visit requirement for mental health services that we just talked about. That was now going to be delayed until January 1 of 2026. Okay. I just want to do a check. I don't see anything happening in the chat. I don't see any hand raised. So let me know if I'm missing anybody's hand. Just take yourself off of mute and smack me in the face.
You're all good right now, Nicole, but I'll keep an eye out.
Okay, appreciate it. Don't hesitate to just interject to stop me. Okay, so now fast forward, we remember we had our final rule, and we're thinking we're all good with telehealth in the non-behavioral health space, because remember, behavioral health therapy has been made permanent. So what we've been able to continue to do is the medical, right? That's what we've continued to get these extensions on primarily, with the exception of the in-person behavioral health visit requirements. So now we get Section 3207 of the American Relief Act 2025 that extended telehealth waivers until March 31 of 2025. So we basically have erased what was in the final rule, and we now have this American Relief Act that says we're only able to do telehealth for non-behavioral health services until the end of March. The guidance in that American Relief Act was that we were getting claims were being paid through March 31 of 25 with the same flexibilities that we had through 2024. We may receive telehealth services regardless of geographic location. Beneficiaries can continue to be in their home. There were no practitioner restrictions. I think right around this time, I don't have it in the slides, but I think right around this time, because of the changes and things that were happening with telehealth, one of the proposed elements was that providers were going to be required to list their home as their service location, but that has not happened. That has not been required. There were many concerns raised about that requirement, so that had never come through as being applicable, okay? And we had, some additional confirmation through the American Relief Act that the in-person mental health services requirement was going to be delayed until January 1 of 2026. Just as an FYI, when you guys get the copy of these slides, these should all be clickable links. So when you're in the slide deck, anything that has this underlined blue should be a clickable link for you. If not, you may be able to just search, if you have trouble with that as a clickable link, just search kind of the description that's here, and you should be able to find the reference that we have. Okay. So fast forward now, we're all kind of watching and waiting and checking on a practically daily basis leading up toward the end of March. And right around, I think it was around March 11th or March 15th, give or take, the Section 2207 of the Full Year Continuing Appropriations and Extension Act of 2025 was released. What that did was it extended the statutory limitations that were in place for the COVID flexibilities around telehealth through the end of September. Okay. At the end of September, unless there was an extension, we were basically going to go back to pre-pandemic. And I say this in such a way that I don't mean any disrespect, but I think we all just expected that it was going to get extended again. There's been so many conversations in DC and in various different states and from a NAC perspective. It's just been general conversation about what's going to happen with telehealth. And I think we had been doing it for so long in the medical space that there was just an expectation in general that it was going to be extended again. And that didn't happen, right? So we're now in a place where we had this extension all the way through the end of September. And basically what we have on this slide was what that Continuing Appropriations Extension Act was outlining for us. We were going to have to go back to pre-pandemic state. We would have geographic restrictions in place. The location restrictions on where services would be able to be provided would be in effect, and limitations on scope of practitioners who can provide telehealth services would also take effect. Now, in the behavioral or mental health space, we would continue to get telehealth wherever the patients are located. There were no originating site requirements, no geographic location restrictions, and the patient was able to be in their home as an originating site for purposes of behavioral or mental health services. And it would be for treating, evaluating, and diagnosing mental health disorders, substance use disorders, and monthly ESRD related clinical assessments. And again, this document indicates that we have a delay in the in-person visit requirements for behavioral and mental health visits until January 1 of 26. I see there's a couple things, but I'm thinking it's not questions that I need to address. So Stephanie, I'll rely on you if I need to pay attention to those.
All good. Thank you, Nicole.
Okay. Okay, so now fast forward, we're leading up to the end of September. There's indications that we could have a possible government shutdown on October 1st. And the clock changes and the calendar changes from September 30 to 9/1, and we have no extension. Okay. We now are in a place where if we come back to this slide, this is where we live on October 1. Okay. Because we didn't get those extensions that we had been used to getting. So when that happened, we're kind of keeping our eyes open for any bits of information that come to us. Now, we're going to talk about this a little bit later, and I'm not going to get into too much of this at this very moment, but I just want to clarify. In the behavioral health space, when we talk about what is permanent for telehealth in Medicare's eyes, we are talking about psychotherapy. We are talking about therapy, talk therapy. We are not talking about the services rendered by a psychiatrist or a psychiatric nurse practitioner that are performing medication management services. I'm going to understand and say that I understand that when a psychiatrist or a psych nurse practitioner is providing that medication, it is for behavioral health purposes. I get that. However, the CPT codes that they are using and that align with the services they are performing are medical in nature. So when a psychiatrist or a psychiatric nurse practitioner or a PCP is doing a medication management visit, even though it may be a medication for behavioral health purposes, that does not qualify as a therapy that is permitted under behavioral health telehealth in Medicare's eyes. Okay, so I want to make sure that we just talk about that. We'll talk about it a little bit more, but I wanted to kind of set that stage before we kind of get into what's been happening since October 1 that we've been watching and checking online for updates. Okay, so we now are in the 10/1 and forward timeline. Okay, on October 15th, there was communication on an update to the telehealth FAQs. When that came out, I saw it the very next day. I didn't see it on the 15th. I saw it on the 16th. When I was seeing a buzz around this release, and there was, some interpretation that, oh, we can now bill and get paid. I had my reservations, and this is from a personal perspective, because I didn't see anything that came out in what I would consider a more official communication from CMS. I consider things like updates to the internet-only manuals. If something was updated in the chapter 9 or chapter 13, if there's a MedLearn matter, that is more of a formal communication, that the way I interpret that. So when I see the FAQ, I had my reservations because yes, the link, and I provided the link here for you all to have and access, but the link is where it references CMS, and that is what has the date of 10/15 in the address bar of the link. The document itself doesn't have any like formal CMS stamps, right? Like there's no like clear CMS labeling. I was trying to think of the right word on the document. So not that I really felt like the document wasn't necessarily, a valid document to some degree, but I had my reservations in what I was reading in there because I couldn't find anything else to support and substantiate it. So there was some conversation around what was in this FAQ that was released on October 15th. Prior to this FAQ coming out, there was communication from some of the MACs, and I pulled this one first because this one came out on 10/1 of 25. And in order of my slides, I probably should have had this first. I apologize. On 10/1 of 25, this link for Noridian came out. And again, just trying to summarize this a little bit here, they basically explained that when legislative payment provisions are scheduled to expire, there's often a hold placed on claims. The hold is typically for 10 days, but knowing that Medicare usually processes claims in 14 days, Noridian is saying we have about 14 days. So this really puts us to right around October 14th, October 15th, give or take. This hold prevents the need for claims to have to be reprocessed should Congress act after the expiration date. Okay. So basically, if you all had performed services during this 10, 14-day window, you would have potentially submitted your claims. But what CMS gave direction to the MACs to do was to hold those claims. Okay. With the expiration of the telehealth effective 10/1 of 25, basically the prohibition of many services provided to beneficiaries in their homes and outside of rural areas and hospice recertification that require face-to-face encounters, that expired. Practitioners who choose to perform telehealth that are not payable by Medicare may want to consider providing beneficiaries with an ABN of non-coverage, because remember, an FQHC or an RHC, you were always able to be an originating site provider. But when you're billing as the distant site provider, that is historically, prior to the pandemic, a non-covered service. So it qualifies for an advanced beneficiary notice being sent to the patients, being provided to the not sent to, but being provided to the patients, so that they're aware that they may get a bill for this service as a non-covered service. Or practitioners, you all have the choice. You can choose to hold the claims yourself. Okay. Now, this last part here, I'm not going to read this whole section to you. It basically says that there's some exceptions for clinicians that apply to the Medicare Shared Savings Program accountable care organizations. I say this with a caveat. It's on here because this is in the communication from CMS and from the MACs, but I say this with a caveat because my understanding from conversations with Aledade specifically, they have said that they are not an ACO that has this exception. So I don't know what ACOs have this exception, but Aledade, and I mention them only because we have a relationship in working with them on some things, but also they're one of the larger ACOs. And they do not meet the criteria from what I've been told. So again, I say that just be very careful in thinking about whether or not you fall into this exception. Okay, so 9:30 was our last day as of 10/1. We're expired for medical telehealth. And we are now in a place where CMS is directing Max to hold claims that may get submitted. I'm going to kind of walk this forward. And again, just over the past couple of weeks. So we then have, and this is where I should have had the order of having that FAQ came out. So the FAQ came out really at this point in time on 10/15. But again, on 10/15, I then, a few days later, with an effective date of 10/15, I see this MLN that comes out. And the MLN, again, gives me a little bit more of a warm and fuzzy. And when I read this section here, absent congressional action beginning October 1, many of the statutory limitations that were in place for Medicare telehealth services prior to the COVID-19 public health emergency took effect again for services that are not behavioral health services. So the confusion around that FAQ that made some think that they could submit and get paid for the non-behavioral health services through the end of December was quickly addressed in this MLN to say, we're still holding claims. We're still in an expiration period that puts us back to pre-COVID-19 pandemic state. Okay. It reassesses or reassures that if there are practitioners who choose to perform telehealth services that are not payable by Medicare on or after October 1, may want to evaluate providing beneficiaries with an ABN. So it reaffirmed that we're still in this holding pattern. Okay. So that was on 10/15. I've provided these additional links for 10/21 and 10/27. These do not say anything different, so I didn't clutter up a slide with this, but I wanted to make sure I provided you all with the links. We're still in a holding pattern for the non-behavioral health telehealth arena. We cannot get paid at this point in time, meaning your claims will not get processed and paid. Could they be paid in the future if CMS and Congress comes back and reinstitutes medical, Medicare, telehealth visits? Possibly, but it's going to depend on what that effective date is. If they retro it back to October 1, or do they make the call from this point forward? So ultimately, medical, I want to say it again, medical telehealth for Medicare, if you are continuing to perform those services, then you are either holding those claims, or if you submit them, they are getting submitted and held by CMS. I see that there's a question about the revenue code and the bill type with the G2025 for Medicare.
Yes, ma'am.
Stephanie, I'm going to follow back up with that because I don't want to speak out of turn, and there's some uniqueness around what information gets submitted with the Q3014 versus the G2025. So if that's okay, I want to make sure I come back to that and maybe send you an email, and could we submit that out to everybody to answer that question?
Absolutely. We'll be sending that in the RCM listserv following mine and Nicole's discussion, Pam. So I'll send you an email so you're aware.
Perfect. And again, I just don't want to speak out of turn, so I want to make sure I give the right information on that. Okay. So again, just kind of thinking about our timeline, what's in store for 2026? The Medicare physician fee schedule proposed rule that came out in July, and I've just included a very small section of what that verbiage was in there. They were proposing policies for non-behavioral health visits furnished via telecommunication technology, allowing RHCs and FQHCs to bill for RHC and FQHC services furnished using telecommunication technology by reporting the HCPCS code G 2025 on the claim, including services furnished using audio-only communications through December 31 of 26. That's what's in the proposed rule. Okay. The final rule would be coming out within the first couple weeks of November. We're still in a position of waiting to hear what happens with Congress coming back into session and what's going to happen with telehealth for the remaining part of this year. And then I would caution that even though we have information that may come out in the final rule, we need to keep our eyes open for other rulings and updates that may come out after the final rule is released, that even if in the final rule they adopt, I was trying to think of the right word, that they adopt what they have proposed, and this says it's going to go through December 31 of 2026. Just like last year for 2025, we saw changes that expired telehealth at the end of March. So we have to keep our eyes open for those things. The other point that I want to mention is there are efforts from different groups for medical telehealth to be made permanent, or to at least make it temporarily permanent, if that makes any sense, through, like, I think it's December of 2027. Okay. But there are efforts to try to make medical telehealth permanent in the Medicare space. Now, before we get into the next few slides around billing and payment, I want to just mention we're focusing on Medicare because that's where we have a lot of buzz and a lot of discussion and a lot of topic going on right now. Okay. We're not addressing the Medicaid and we're not addressing the commercial in today's discussion. We would need to I always say this, those of you who know me, I work across the entire country. So because the state rules change often in different areas, before I confirm anything in a state perspective, I always like to just verify that what is the state looking like today. Now, I will say that during the COVID pandemic, during that public health emergency, many of the states made telehealth permanent, and they pay telehealth the same as what they pay for an in-person visit. So I would just encourage, if anybody has questions around that Medicaid telehealth space, that there be research and checking with a state to make sure that there isn't anything that changed, right? And then the same thing with our commercial payers, and I'm going to include Medicare Advantage in this space. Ultimately, check with those individual payers on what their rules are and know what they do, what they cover, if it's based on an individual patient's plan, what their reimbursement structure is. All of that is really important to know when you're thinking about your commercial payers and your Medicare Advantage payers. So I just kind of wanted to mention that in case anybody's thinking about it, or you have that in the back of your mind, I wanted to kind of address that so that I don't want to leave you hanging in that space. All right, I'm going to just stop for a quick second before we get into the billing and the payment side of things. Stephanie, I see there's conversation, which I love, in the chat. Is everybody getting what they need through the chat, or is there something that I can help address?
Carla Townsend just shared with us the Medicare FQHC updates from NAC. So she had just shared that, and I mentioned that we would share it following this call. But that's the only discussion that we have going on in there right now.
Okay.
But then Chuck did add a note that these things are changing daily lately.
Yes.
So good point to
Yes,
make.
that's, I was gonna say, if this is, again, just kind of be careful and check your sources. And I don't mean to say that NAC is not a reliable source. That is not what I am saying. I'm just saying in general, we have to check our sources and check our information to make sure that the way we're operating is appropriate and compliant, and that we're not, in a position where we could potentially have to pay back money if we were to get paid. And just kind of keeping our eyes open, because this is just an ever evolving topic that we're contending with right now.
Nicole.
Okay. So when we get into the billing and payment, I want to come back to starting from the originating site. An FQHC and an RHC, you can separately bill. No other visit needs to be reported. You would use revenue code 0780 with HCPCS code Q3014. Okay. That is subject to Part B coinsurance, and the payment for 2025 nationally was listed as 3101. Could be different and slightly different for different geographic locations. And then you've got your coinsurance that would get applied to that as the 20%. So if you have patients that are coming into your clinic and you are functioning as the originating site, you are able to bill this Q code, and there is some reimbursement for this service on the originating site side of things. For the G2025, we apply the CS modifier for any telehealth services for which coinsurance would have been waived. Now, please note, this is through 9/30 of 2025 in terms of being a covered service. If you choose to submit your claims now, even though CMS will hold them, this still applies with the use of the CS modifier. What I'm saying here is, for an example, would be an annual wellness visit. That service does not have coinsurance. So if you were to have performed G0439, which is your subsequent annual wellness visit in the form of telehealth, you would submit your claim with G2025 with the CS modifier. We are not required or expected to report the HCPCS code from the list of telehealth services. If you do, I will be honest with you, I don't know if Medicare was just ignoring those additional HCPCS codes on there or what they may have been doing. But the guidance is that we do not report the HCPCS code. So the way it's been structured in the medical space, there's no detail of what was actually performed in terms of the specific service that was performed via telehealth. And the payment allowed amount is $94.45. So keep in mind that when we submit and perform a telehealth medical visit, the payment is less than what we are getting paid for an in-person visit. Now, again, I don't say that to say payment should drive the decision of how we care for our patients and the services we perform, but we have to be aware financially that there is a lower payment, there is a lower allowed amount for a medical telehealth visit than what it is for an in-person medical visit. Remember, for calendar year 2025, our base rate is $202.65 that then gets adjusted geographically for your location. And your new and annual wellness visits have a 34% adjustment above that. So nationally, it's roughly $270 or $271 that then gets adjusted geographically. So again, thinking about this, from a high level CFO budgeting kind of perspective, if we budgeted for X number of visits in person and we're transitioning those, or we've done those to telehealth, our visit numbers may be the same, but our revenue will be less if we've shifted in-person visits to telehealth. Okay. So again, I just kind of want to say that I know we've got an audience of of varying different individuals in roles. So I just kind of want to address this from a couple of different angles to give you guys as much information as possible. On the behavioral health or the mental health side, when we submit our claims for telehealth, we submit them with revenue code 0900. We use HCPCS code G0469 or G0470. We list our qualifying code, which is our 90791 or 90792, and then there's a series of 9083 codes that are considered our qualifying codes. And this is where we utilize the modifiers of the FQ or the 93 that says this was performed audio only, or the 95 that it was audio video. If it was an in-person visit, you're just not submitting any of those modifiers, okay? This, and I apologize, I should have fixed this. I could fix this and then send this back out to you, Stephanie, to distribute to everybody. This is not appropriate. I apologize. This should not say through 9/30/2025. So Stephanie, if you're okay with that, I'll fix this and send this out to you as well, right when we get done with our call. Because this,
Perfect.
the behavioral health piece doesn't go through 9/30. This is permanent. So I apologize. I thought I fixed that. This part is what's applicable through 9/30. This is that psychiatrist or psych nurse practitioner visit that I briefly talked about. When they perform a medication management visit, they're performing and documenting, and this is through conversations that I've had with other individuals, peers, colleagues. They're performing a medical E&M visit, and they are excuse me, assigning a 99202 through 99215 for that medication management visit. It is possible that a psychiatrist or a psych nurse practitioner would perform one of those other qualifying codes that we talked about, but we have to make sure that what they're performing is what's documented and the coding matches that, okay? In this scenario of what we're showing on the screen, these services under medication management is not considered behavioral health, it's considered medical. So these would not qualify for current payments from Medicare in the telehealth space. These would be claims that would get billed with the G2025 and no modifiers or anything, and they're getting held, okay? What does the future look like? If I had that crystal ball, I would share it with everyone and anyone that I could share this information with, but I don't. I don't know what's going to come about. We have to keep watching. We have to keep checking. We have to continue to communicate through our PCA groups and through other individuals on the benefits and the impacts and what we really want to advocate for so that our voices are heard to be able to care for patients appropriately. I am not advocating that you need to not do telehealth or you do telehealth. Those are decisions that you all in the health center space need to be able to take the information that is available to you and make the decisions that are in the best interest of your patients and your health centers in your community. With that said, there's also then a slide for various different additional links. And then I want to now open it up to some questions that anybody may have. If anybody has anything that you want to talk about a little bit more based on what we talked about today.
Nicole, this is Chuck. Just to clear up any confusion, and I think you covered it on the slide, but just to reiterate, the way that I understand it, the FY25 physician fee schedule is actually it's a federal regulation. In order for the regulation to be acted on, it has to be statutorily authorized. So the way that I look at it is, although telehealth flexibilities were extended in the FY25 physician fee schedule, because the federal government shut down on 10/1, there's no statutory authorization to enable its contents. Is that correct?
Yes.
Okay, so that's why when we talk about, like, I get things daily for the folks that are on the call. We all get things daily on interpretations from CMS, interpretations of law from Powers, from Veldsman, from Forbes on different things, and so we've got a lot of documents that are older that were released earlier in the year, earlier in 2025, that were giving guidance based on the FY25 physician fee schedule. That when the government was allowed to shut down, a lot of those flexibilities went away. So documentation and guidance that you have prior to October 1st related to Medicare telehealth is probably not 100% reliable. Is that safe to say?
I would agree with that statement. The one thing that I guess would be a good point to kind of mention as part of that, and I apologize, I didn't mention this earlier. I want to come back to the in-person visit requirement for the behavioral health piece. What I want to point out there is if you read the documents like Chuck was just talking about, there's information that says that that continues until January 1 of 2026. But when you look at what came out in the continuation act that had everything expire as of 10/1 or 9/30, there's confusion about that in-person visit requirement. Does that really expire September 30th or October 1st, or does it expire January 1 of 2026? So there's different interpretations on when that in-person visit requirement is expiring. Many of our health centers are just making the decision to assume, and I know we need to, be careful when we assume, but they're moving forward, maybe is a better way to say, in thinking that it expired October 1st. So the clock started ticking in their eyes as of October 1st, with requiring an in-person visit for behavioral health services. So in their eyes, they're saying we have until the end of March of 2026 to bring these patients in for an in-person visit to meet that 6-month requirement. And then once they meet that 6-month requirement, the expectation is that annually thereafter, there is at least one in-person visit that patient has from a behavioral health perspective. So some health centers are saying we're looking at this and it starts January 1st because that's what this other guidance tells us. And we're going to go off of the January 1st, and that gives us until the end of June. Others are saying we're thinking of this as the clock starting to tick on October 1st. So again, there's different interpretation of the information that is being disseminated in this telehealth space.
Thank you for that clarification, Nicole.
Sure, absolutely.
Do we have any additional questions, comments that we want from Nicole's presentation today? Before I go into just a couple of updates. Okay. Well, I just wanted to thank you so much, Nicole, for that presentation, first of all.
You're
I just
welcome.
wanted to give a quick update. You all likely received, and I'll share my screen to show you before we hop into this poll. I just wanted to make sure you all were aware. Oh, sorry, Chuck. I just overrid your screen sharing.
No, you're good. Go ahead.
Sorry
I
about
was
that.
getting ahead of myself.
No worries. I just wanted to share, you all should have received an email from Revenue Cycle Management Listserv on Friday. So this is a new platform that we are going to utilize to be sending like those MCO updates that are on a global level, and just like different materials from presentations, and then anything else that we think relates to the revenue cycle space. It's also a great platform for networking and just has a lot of great opportunities. So if you did not, first of all, if you received this email, you are already added to the listserv group. You are good to go. If somebody did not receive this email, or if there's an additional person you would like to add, just shoot myself or Chuck O'Neill an email and we will easily get you added. But following this call, once we have the slides, we will distribute the slides each meeting following in this listserv group. So that's all I wanted to add. And then I know Chuck wanted to talk real quick on a poll, if you all don't mind. And I'll stop sharing for you, Chuck.
All righty. Yeah, so we're just going to share an evaluation poll with you guys, if you don't mind to complete this for us. It'd be very helpful to us in serving your needs going forward. And if you complete it, we will email the slides out to those folks that complete this for us. And we appreciate it very much. And we appreciate Nicole being with us and Forbes for their partnership.
Thank you for having us. We appreciate being part of your group and always happy to help.
Can you guys see the poll on the other end? I haven't used this feature before and actually set it up for us. So
Yeah,
I
looks like
see,
you got some responses coming in too.
okay,
yeah, I
great.
wasn't answering it, but I see it popped up on my screen if it helps.
Great, thank you.
And before we hop off, I do just want to add that if there are topic suggestions that you have, things that you would really like to discuss in these meetings, please send them over because we are always open to suggestions. And once you've completed your poll, that's all we have for you today. So if you need anything else, please feel free to shoot us an email. And thank you guys so much for gathering today.
Have a great Halloween, everyone. If you celebrate, be safe and have fun scaring people if you like to do that, I guess. Stephanie, do you need me to